If you are over 60 and taking Lisinopril, there is a very real chance you were handed that prescription with a brief explanation about blood pressure and a mention that some people develop a cough. And if you are in that group, I want to tell you something important before this video goes any further. What you were told was not wrong, but it was profoundly incomplete. And the part that was left out is where the serious problems tend to happen. I am Dr. Catherine Morales, cardiologist. And I want to walk you through 11 side effects and interactions related to Lisinopril that matter specifically to people over 60 in plain language, with the clinical detail that most 15-minute appointments simply do not have time to deliver. Not to alarm you, not to convince you to stop your medication, but because understanding what this drug does inside your body and what can go wrong in specific circumstances is the difference between being a passive patient and an informed one. Lisinopril is one of the most prescribed medications in the United States. It belongs to a class called ACE inhibitors, which stands for angiotensin-converting enzyme inhibitors. In simple terms, it blocks a hormonal chain reaction that causes blood vessels to tighten, which lowers blood pressure and reduces the workload on the heart. It is prescribed for high blood pressure, heart failure, kidney protection in diabetics, and recovery after a heart attack. It has decades of safety data behind it. For many people, it is genuinely life-prolonging. But over 60, the body around the medication is different in ways that change the risk profile. The kidneys filter more slowly. The blood vessels are less elastic. The regulatory systems that adjust blood pressure moment to moment are less responsive. Drug interactions accumulate because older adults are more likely to be on multiple medications. And side effects that a 40-year-old would notice and report can present so gradually, so quietly in a person over 60 that they are attributed to aging and never connected to the pill. That is exactly the pattern I want to break today. So let us count down from 11 to 1, saving the most critical truth for last. The side effect most people know about Lisinopril is the cough. Most people do not know why it happens, when to take it seriously, or what distinguishes a drug-related cough from something that requires urgent medical attention. Norma was 68, a retired librarian who developed a dry, persistent tickle in her throat about 3 weeks after starting Lisinopril. She assumed it was allergies, then a lingering cold, then the dry air in her bedroom. She ran a humidifier. She took Robitussin DM, available at any drugstore, which helped slightly but not consistently. 8 months passed before her doctor, reviewing her medication list during an unrelated visit, made the connection. Here is the mechanism. ACE inhibitors like Lisinopril block the enzyme that breaks down a substance called bradykinin. When bradykinin accumulates in the airway tissues, it triggers a dry, non-productive cough in approximately 10 to 15% of patients. In patients of Asian descent, the rate can be as high as 30 to 40%. The cough has a specific character. It is dry, persistent, tickling rather than wet, and does not produce mucus. It does not come with fever, shortness of breath, or chest pain in its isolated form. The reason this matters beyond the annoyance is twofold. First, many seniors tolerate the cough silently for months or years, assuming it is a fixed cost of the medication, when in fact it is a known, manageable side effect with a clear solution. Switching to a different drug class, specifically an ARB such as losartan or valsartan, achieves the same clinical goals without bradykinin accumulation and typically resolves the cough within 1 to 4 weeks. Second, and more urgently, a cough that develops on Lisinopril alongside any of the following requires immediate evaluation: shortness of breath, facial or tongue, swelling, wheezing, or a sensation of throat tightening. Those symptoms are not the Lisinopril cough. They are angioedema, which is the next entry on this list, and the one that requires an emergency response. Angioedema is the most acutely dangerous side effect associated with Lisinopril, and it is the one least understood by the patients who are most at risk for it. Douglas was 73, a retired engineer who had been on lisinopril for 2 years without incident. One evening after dinner, he noticed his lower lip felt unusually full. By the time his wife noticed, his lip had swollen to twice its size. His tongue felt thick. He had no rash, no hives, no difficulty breathing yet, but his voice had changed slightly. His wife drove him to the emergency room. He arrived within 30 minutes of the first symptom, which was fortunate. Angioedema is a rapid swelling of the deep skin layers, most commonly affecting the face, lips, tongue, throat, and in some cases, the gastrointestinal lining. When it involves the tongue or throat, it can obstruct the airway and become life-threatening within minutes. It occurs in approximately 1 in 1,000 patients on ACE inhibitors, but in patients over 60, in patients of African American descent, and in patients with a prior history of any type of angioedema, the risk is meaningfully higher. One of the most dangerous features of lisinopril-related angioedema is its timing. It does not occur only at the start of treatment. The majority of cases occur in patients who have been on the drug for months or years without any prior reaction. This means that a patient who has tolerated lisinopril well for 2 years cannot assume they are immune. The reaction can be triggered by a change in kidney function, an interaction with a newly added medication, or with no identifiable trigger at all. If you or anyone in your household takes lisinopril and you observe sudden swelling of the lips, tongue, face, or throat, that is a 911 call, not a drive to urgent care, not a wait and see, not an antihistamine from the cabinet. The window between early symptoms and airway compromise in severe angioedema can be measured in minutes, and the definitive treatment requires epinephrine and airway management that cannot be delivered outside a hospital setting. Every patient on lisinopril should know this scenario by name and know exactly what to do when they see it. The third entry involves the kidneys, and it is the side effect most likely to be happening right now in a patient who has no symptoms, no warning, and no idea that their laboratory values tell a different story than how they feel. Agnes was 71, diabetic, well-managed, taking lisinopril specifically because her endocrinologist had prescribed it for kidney protection, which is one of its well-established benefits in diabetic patients. For 2 years, her creatinine levels remained stable. Then her husband was hospitalized for a hip fracture, stress entered the picture, her eating pattern changed, she was mildly dehydrated for several weeks, and at her next routine blood draw, her creatinine had risen enough to signal early acute kidney injury. Here is the paradox that confuses patients and families. Lisinopril is prescribed to protect kidneys in diabetics and heart failure patients, and it does provide that protection under stable conditions. But lisinopril works by dilating the blood vessels that feed the kidney, specifically the efferent arteriole, which reduces the filtration pressure inside the kidney's tiny filtering units. Under normal circumstances, this is beneficial. It reduces the strain on the filters. But when blood volume is reduced, whether from dehydration, illness with vomiting, or diarrhea, fever, or excessive diuretic effect, that same dilation can reduce kidney blood flow to the point where the kidneys cannot maintain adequate filtration. This is called the triple whammy effect when it occurs in combination with a diuretic and an NSAID pain reliever, and it is one of the most common causes of drug-induced kidney injury in adults over 60. Lisinopril alone rarely causes this problem in a well-hydrated, stable patient. Lisinopril plus a diuretic plus ibuprofen or naproxen during a period of illness or reduced fluid intake is a combination that can reduce kidney function measurably within days. The practical implication: every patient over 60 on lisinopril should have their kidney function and potassium checked at least annually, and more frequently if there is diabetes, existing kidney disease, heart failure, or regular diuretic use. And every patient should know to contact their doctor during any illness involving significant vomiting, diarrhea, or inability to maintain normal fluid intake. The sick day conversation is not optional for this medication. Side effect number 8 is one that hides in plain sight because its symptoms are identical to what aging itself produces. Lisinopril can cause or worsen low blood pressure, and the most dangerous version of this does not happen when you're sitting quietly. It happens when you stand up. Raymond was 69, a former teacher who had been on lisinopril for 3 years. His sitting blood pressure was well controlled. He had no complaints at his regular appointments. Then, his cardiologist added a diuretic to improve his fluid management, and within 2 weeks, Raymond began experiencing what he described as a head rush every time he got up from the sofa. He sat back down and waited for it to pass, which it did within seconds, and he said nothing about it for 6 weeks because it seemed like such a small thing. It was not a small thing. What Raymond was experiencing was orthostatic hypotension, a drop in blood pressure upon standing that is directly amplified by ACE inhibitors and further amplified by diuretics. In older adults, the autonomic reflexes that normally compensate for positional changes in blood pressure are already slower and less precise than they were at 40. Blood pressure medication reduces the available pressure reserve further. When the two combine with a new diuretic, the result is a predictable window of circulatory insufficiency in the few seconds after standing when the brain receives less blood than it needs. In those seconds, the risk of a fall is real, and the consequences of a fall in a person over 60 are serious. Hip fractures in adults over 70 are associated with a 1-year mortality rate of approximately 20%. That statistic does not come from dramatic accidents. A significant portion comes from exactly this scenario: a medication combination, a positional change, a moment of dizziness, and a floor that arrives faster than the hand reaching for the doorframe. The management involves both medication review and behavioral strategy. Sit on the edge of a chair or bed for 30 seconds before standing. Rise slowly, ensure adequate hydration. And if dizziness upon standing is occurring more than occasionally, report it specifically because it is a signal that medication timing, dosing, or combination may need adjustment. Do not normalize it. Do not file it under getting older. Report it. Lisinopril raises potassium levels. This is a known pharmacological effect. It appears on the drug label, and in most patients, it is manageable and clinically insignificant. In specific circumstances, however, it creates a hidden cardiac risk that is far more serious than the mild laboratory abnormality it appears to be on paper. Harriet was 66, health conscious, and proactive. When her doctor prescribed lisinopril, she read that high blood pressure was related to excess sodium and that potassium helped counteract sodium's effects on blood vessels. She began taking a potassium supplement, specifically nature-made potassium gluconate, available at Costco and most pharmacies, at 550 milligrams daily. She also switched to new salt potassium chloride salt substitute, available at most grocery stores, because she had read it was heart-friendly. She told no one because none of these were prescription medications. At her next blood draw, her potassium was 6.1 millimoles per liter. Normal upper limit is 5.0. At that level, the electrical system of the heart begins to malfunction. The rhythm becomes unpredictable. The risk of a dangerous arrhythmia, including ventricular fibrillation, increases in ways that cannot be predicted from symptoms alone. Harriet had felt mildly fatigued and noticed occasional muscle weakness, symptoms she had attributed to being busy. Her electrocardiogram showed early changes consistent with hyperkalemia. ACE inhibitors like lisinopril raise potassium by reducing the amount excreted through the kidney. This effect is amplified by any additional potassium source. Supplements, potassium-based salt substitutes, high potassium foods consumed in large quantities, such as bananas, oranges, tomato products, and potatoes, and by reduced kidney function that impairs excretion further. The risk is compounded when lisinopril is combined with other potassium-sparing medications, including spironolactone and eplerenone. Patients on lisinopril should not take potassium supplements without explicit medical guidance. Potassium-based salt substitutes, including new salt and Morton salt substitute, both widely sold in grocery stores, should be discussed with a physician before use. This is not a theoretical warning. It is a documented cause of cardiac arrhythmia in older adults who were doing exactly what they believed was right for their heart health. Lisinopril interacts with a class of over-the-counter pain medications in a way that undermines blood pressure control, stresses the kidneys, and is occurring in millions of patients right now, without any of them realizing the two things are connected. Clarence was 72, a man who managed chronic lower back pain with ibuprofen. He took Advil Liqui-Gels, manufactured by Haleon and available at every pharmacy and most grocery stores, at 400 milligrams twice a day on most days. He had done this for years before his Lisinopril prescription and continued afterward without mentioning it to his prescribing physician because ibuprofen was not a prescription medication and he had not thought to bring it up. His blood pressure remained above target despite 2 dose increases over 18 months. His doctor attributed this to resistant hypertension and considered adding a third medication. A medication review prompted by a pharmacist during a routine counseling session at his local CVS identified the interaction. The ibuprofen was discontinued. Within 4 weeks, his blood pressure came down to target on the same dose of Lisinopril he had been taking all along. NSAIDs, including ibuprofen sold as Advil by Haleon, naproxen sold as Aleve by Bayer, and prescription-strength NSAIDs work by blocking prostaglandins in the kidney. Prostaglandins are partially responsible for maintaining the dilated state of the blood vessels that lisinopril depends on to lower blood pressure and protect the kidney. When NSAIDs block prostaglandins, they partially reverse the mechanism lisinopril relies on to function. The result is blunted blood pressure control, increased sodium retention, and elevated cardiovascular strain, all invisible to the patient because neither medication announces the conflict. Acetaminophen sold as Tylenol by Kenvue does not carry this interaction for most patients and is the appropriate alternative for routine pain management in anyone taking lisinopril. For patients whose pain cannot be adequately managed with acetaminophen, a topical NSAID such as diclofenac gel sold as Voltaren by Haleon, applied directly to the affected area, provides local anti-inflammatory effect with substantially less systemic absorption and a correspondingly lower impact on blood pressure and kidney function. Side effect number 5 is not a side effect in the traditional sense. It is a consequence of a gap in monitoring that is nearly universal in patients over 60 on lisinopril, and that gap creates a window of invisible risk that can persist for months before anything visible or symptomatic alerts anyone to a problem. Vivian was 74, a woman who had been on lisinopril for heart failure management for 4 years. Her cardiologist monitored her carefully for the first year with frequent blood tests. As she stabilized, the interval between tests lengthened. Then, her insurance changed. Her cardiologist retired, and there was a gap in care during which she saw only her primary care physician, who managed her ongoing prescriptions but did not have the full cardiac history that had guided the original monitoring protocol. 18 months passed without a kidney function or potassium test. When testing was eventually ordered during a hospitalization for an unrelated reason, her potassium was elevated, her creatinine had risen significantly above her prior stable baseline, and her hemoglobin had dropped, a finding consistent with reduced erythropoietin production from kidney stress. None of these changes had announced themselves. Vivian had felt tired, but she had attributed this to her heart condition and her age, neither of which was incorrect, but both of which had become convenient explanations for a signal that warranted investigation. Lisinopril requires ongoing laboratory surveillance, not just initial monitoring. Kidney function measured by creatinine and eGFR, potassium level, and in diabetic patients, urinary protein should be checked at least annually in stable patients and every 3 to 6 months in patients with diabetes, existing kidney disease, heart failure, age over 75, or any recent change in medication or clinical status. If you are on lisinopril and cannot recall the last time these values were checked, that is the most important conversation to have at your next appointment. Lisinopril can cause a rapid and dangerous drop in blood pressure with the very first dose. And while this is most pronounced in certain specific patient profiles, it is a risk that is almost never explained directly to the person opening the bottle for the first time. Walter was 68, recently diagnosed with heart failure, and started on a low dose of lisinopril as part of his management plan. His cardiologist had appropriately started at 2.5 milligrams, the recommended initiation dose for heart failure. What the office team did not walk him through clearly was what to expect in the first few hours. Walter took his first tablet after breakfast, went to his afternoon garden, and 45 minutes later felt profoundly lightheaded and had to sit down on the ground because he could not make it to a chair. His wife found him there, pale, unable to stand without assistance. First-dose hypotension with ACE inhibitors is most pronounced in 3 patient groups: those who are volume-depleted from diuretic use, those with severe or poorly controlled hypertension at baseline, and those with heart failure and already low blood pressure reserves. In these groups, the vasodilating effect of the first dose can exceed what the cardiovascular system can compensate for, producing a sudden, significant blood pressure drop that in some patients leads to syncope and in some of those to falls and injury. The standard clinical guidance for patients at higher risk is to take the first dose at night before bed, so that if the blood pressure drop occurs, the patient is already lying down and the fall risk is minimized. For patients not identified as high risk, a general awareness of the first dose effect is still appropriate. Avoid strenuous activity for 2 to 3 hours after the first dose. Stay well hydrated. Have someone available if possible. And know that if dizziness or faintness occurs, sitting or lying down immediately rather than pushing through it is the right response. Lisinopril is processed and eliminated almost entirely by the kidneys. This single fact has profound implications that extend far beyond blood pressure management, and in a patient over 60 whose kidney function is declining gradually and silently with age, it means the lisinopril prescription that was calibrated correctly at 62 may be delivering significantly more drug than intended by 68. Frederick was 71, a meticulous man who had taken the same 20 milligram dose of lisinopril for 7 years. His blood pressure was well controlled. He felt the drug was working and saw no reason to question it. Over the same 7 years, his kidney function had declined from an eGFR of 72 to an eGFR of 48, a reduction that placed him in stage 3 chronic kidney disease. Neither he nor his primary care physician had connected the declining eGFR to the stable lisinopril dose. As kidney function declines, lisinopril is cleared from the body more slowly. The same daily dose that produced a specific blood level at an eGFR of 72 produces a higher blood level at an eGFR of 48, because the kidneys are no longer clearing it at the same rate. The drug accumulates. The blood pressure lowering effect intensifies. The potassium raising effect intensifies. The kidney blood flow effect intensifies. All of this happens without any change to the prescription, without any change in the patient's behavior, and without any obvious symptoms until the accumulation crosses a threshold that produces measurable changes in laboratory values or clinical signs. This is why lisinopril dosing recommendations from the FDA specify reductions for patients with reduced kidney function, with more conservative targets for patients whose eGFR falls below 30. It is also why knowing your eGFR is as important as knowing your blood pressure if you are over 60 and on an ACE inhibitor. Your doctor should be adjusting the conversation about your lisinopril dose as your kidney function changes over time, not waiting for a clinical event to prompt a review. Side effect number 2 is one that most patients would never connect to a blood pressure medication, and yet it is documented in the medical literature. It is biologically plausible. It carries a real injury risk in older adults, and it is the side effect most likely to be present in a patient sitting in an exam room describing a problem that has gone unexplained for months. Lisinopril and other ACE inhibitors can cause or worsen a taste disturbance and loss of appetite that in older adults already at risk for inadequate nutrition contributes to a pattern of weight loss, muscle loss, and frailty that compounds every other cardiovascular risk factor the medication was prescribed to manage. Gloria was 69, a woman who had always enjoyed cooking and eating. 8 months after starting lisinopril at a higher dose following a blood pressure target revision, she mentioned to her daughter that food did not taste the same anymore. It was not completely absent, but metallic, flat, less satisfying. She was eating less. She had lost 9 pounds over 5 months. Her doctor, noting the weight loss, ordered tests for malignancy and gastrointestinal problems, none of which revealed anything. The lisinopril was not on the list of suspects until a clinical pharmacist reviewed her complete medication list with attention to this specific side effect category. Taste disturbance, known clinically as dysgeusia, is a recognized side effect of ACE inhibitors. It is believed to result from zinc depletion that can occur with the medication, as ACE is a zinc-dependent enzyme, and its inhibition may affect zinc metabolism and availability in the taste receptor cells. The effect is dose-dependent, more common at higher doses, and often resolves or improves with dose reduction or a switch to an ARB. In an older adult where 9 pounds of unintended weight loss represents a significant proportion of lean body mass, and where sarcopenia and frailty are already emerging risk factors for falls, hospitalization, and cardiovascular events, this is not a minor quality of life side effect. It is a clinically meaningful consequence. If you have noticed changes in your sense of taste, a metallic quality to food, a reduction in appetite, or unexplained weight loss since starting or increasing lisinopril, raise it specifically at your next appointment and ask whether it may be medication-related. And that brings us to the side effect that sits above all the others on this list. Not because it is the most dramatic or the most acute, but because it is the one that is most consistently misunderstood, most commonly mismanaged, and most likely to produce a serious outcome in a patient over 60 who has never been given the complete picture. It is this. Lisinopril controls blood pressure only as long as it is taken consistently, and in the specific population of patients over 60 with heart failure, post-heart attack care, or diabetic kidney protection, stopping lisinopril without medical guidance can accelerate the very outcomes the medication was prescribed to prevent. Bernard was 76, a sharp and independent man who had started lisinopril after a mild heart attack 2 years earlier. He tolerated it reasonably well, but during a period of feeling generally unwell, he read online that ACE inhibitors were sometimes overprescribed and that some patients did better managing blood pressure through lifestyle. He felt his blood pressure had been good for months. He felt like he no longer needed the medication. He stopped it over a weekend without calling anyone. Over the following 3 weeks, his blood pressure rose. His cardiac remodeling, the process by which the heart muscle adapts and sometimes deteriorates in the period following a heart attack, progressed without the neurohormonal protection lisinopril had been providing. At his next appointment, his echocardiogram showed a measurable decline in ejection fraction, the percentage of blood the heart pumps with each beat, that had not been present 3 months earlier. He was restarted on lisinopril, and a second medication was added to compensate. Here is the truth that every patient on lisinopril deserves to hear once, clearly and completely. Feeling well on lisinopril is frequently the direct result of what lisinopril is doing. The blood pressure is controlled because the medication is controlling it. The heart is not remodeling adversely because the medication is preventing it. The kidneys are being protected because the medication is protecting them. The absence of symptoms is the product of the treatment, not evidence that the treatment is no longer needed. This does not mean lisinopril is appropriate for every patient indefinitely. There are medically supervised situations where ACE inhibitors are reduced, changed, or discontinued, including significant kidney function decline, pregnancy, certain allergic reactions, and some combination adjustments. But those decisions are made with clinical data, laboratory monitoring, and a physician who knows the full picture. They are not made on a weekend because a person feels well and has read something online. If you have concerns about your lisinopril dose, about side effects you are experiencing, about whether the medication is still appropriate for your situation, those concerns are legitimate and deserve a real conversation. Write them down. Bring them to the appointment. Ask the question directly. Is this dose still right for where my kidneys, my heart, and my blood pressure are today? That question, asked and answered with current laboratory data in front of your physician, is exactly how medication management should work. What it should not be is a solitary decision made without the information that only clinical monitoring can provide.